Welcome to a video on monogenic hypertension. After watching this video on monogenic hypertension, you are expected to know end organ effects and major clinical manifestations associated with the different forms of monogenic hypertension herein presented. You are also expected to be able to identify clinical manifestations and specific therapeutic options for the different monogenic hypertensive conditions. 95% of hypertension cases have no identifiable causes and are classified as primary hypertension. The underlying mechanisms of primary hypertension are thought to be due to a combination of genetic and environmental factors. 5% are classified as secondary hypertension, where the hypertension can arise from a number of causes. Of these, a small subset have monogenic hypertension, where the hypertension arises from one specific mutation. Monogenic forms of hypertension are worth learning about because they can give us a greater appreciation of normal physiology and a chance to recognize and properly treat rare forms of hypertension. Monogenic hypertension is due to either increased renal sodium reabsorption or increased vascular resistance and vasoconstriction. So how do various mutations lead to increased renal sodium reabsorption and hypertension? Sodium reabsorption occurs along the entire nephron. Monogenic forms of hypertension that results from increased sodium reabsorption have to do with mutations that can increase sodium reabsorption at either the distal convoluted tubules or collecting ducts. Let's first review how sodium is reabsorbed at these nephron segments. Filtered sodium that escapes reabsorption at proximal tubules and thick ascending loop of Henle may get reabsorbed at distal convoluted tubules or collecting ducts. Sodium reabsorption at distal convoluted tubules occurs via the sodium chloride cotransporter NCC. Calcium is also reabsorbed at the distal convoluted tubules via calcium channels. Sodium not reabsorbed at the distal convoluted tubules may get reabsorbed downstream at the collecting duct via the apical epithelial sodium channel (ENaC) in principal cells. Here, sodium reabsorption occurs in exchange for potassium secretion. Sodium entry at the principal cells create a negatively charged lumen that also favors hydrogen secretion from alpha intercalated cells. Sodium reabsorption and potassium and hydrogen secretion are stimulated by aldosterone upon binding to mineralocorticoid receptors on principal and alpha intercalated cells. One form of monogenic hypertension that results from an increase in renal sodium reabsorption is due to a gain-of-function mutation of the sodium chloride cotransporter NCC at distal convoluted tubules. This condition is known as pseudohyperaldosteronism type 2 or Gordon syndrome. In patients with familial hyperkalemic hypertension, also known as pseudohypoaldosteronism type 2 or Gordon syndrome, there are a number of mutations involving regulatory molecules that can increase the activity of the sodium chloride cotransporter NCC. Increased sodium chloride reabsorption at NCC causes volume expansion, thus hypertension. Since NCC activity is high in this condition, most of the sodium delivered to this segment will be reabsorbed by NCC. This means only a small amount of sodium will be left behind to be delivered to collecting ducts for reabsorption via ENaC. When there is reduced sodium entry via ENaC, there will be reduced potassium and hydrogen secretion. Hyperkalemia and metabolic acidosis ensue. In some patients, there may also be increased paracellular reabsorption of chloride, which also contributes to volume expansion and hypertension. Of note, when there is increased sodium chloride reabsorption and volume expansion, the renin-angiotensin-aldosterone system will be downregulated. This means these patients will have low levels of renin and aldosterone. Low aldosterone reduces potassium and hydrogen secretion and contributes to hyperkalemia and metabolic acidosis. Other phenotypes that may be seen in Gordon syndrome include reduced ROMK activity, which can also contribute to hyperkalemia, and reduced expression and activity of the calcium channel. This can reduce calcium reabsorption and cause hypercalciuria and osteoporosis. Familial hyperkalemic hypertension, also known as pseudohypoaldosteronism type 2 or Gordon syndrome, is a rare autosomal dominant heterogeneous syndrome. This condition may be suspected in patients with spontaneous hypertension, hyperkalemia, and metabolic acidosis, plus or minus hypercalciuria and osteoporosis. Implicated mutations include the with-no-lysine kinases WNK1, WNK4, Kelch-like 3, and colon-3. The key effect from all associated mutations is the gain of function of the sodium chloride cotransporter NCC. Patients with this condition have low renin and low aldosterone levels due to the primary increase in sodium chloride reabsorption and volume expansion. Treatment may include low dietary sodium restriction and the use of NCC inhibitors, which are thiazide diuretics. Another form of monogenic hypertension that results from an increase in renal sodium reabsorption is due to a gain of function mutation of the epithelial sodium channel ENaC in collecting ducts. This condition is known as Liddle syndrome. In patients with Liddle syndrome, there is a gain of function mutation involving the epithelial sodium channel ENaC in principal cells of collecting ducts. There is a peptide segment on ENaC called the PY motif that is normally recognized for cytosolic internalization and degradation. Mutations affecting the PY motif of ENaC interferes with cytosolic internalization for degradation. This results in an increase in the number of functioning ENaC on the apical membranes and increased sodium reabsorption. It is this increase in sodium reabsorption that causes hypertension. The increased sodium reabsorption via ENaC generates a highly favorable electrochemical gradient that serves to enhance potassium and hydrogen secretion. This leads to hypokalemia and metabolic alkalosis, respectively. A little more about Liddle syndrome. Liddle syndrome is an autosomal dominant condition where there is a gain of function mutation of the epithelial sodium channel ENaC in collecting ducts. The mutation is in the PY motif of ENaC. Think of the PY motif as the cytosolic tail of ENaC. The PY motif is the peptide segment necessary for recognition by a process that internalizes and degrades ENaC. ENaC with a mutated PY motif tail cannot be internalized and degraded. This results in an accumulation of functioning ENaC on the apical cell membrane, hence the increase in sodium reabsorption and hypertension. The average age of onset is 15 years old but may occur in adulthood. Affected patients present with hypertension due to increased sodium retention. The resultant volume expansion leads to low renin and low aldosterone levels. Nonetheless, patients with Liddle syndrome present with hypokalemia and metabolic alkalosis. This is due to facilitated potassium and hydrogen secretion in collecting ducts via the favorable electrochemical gradient generated by enhanced ENaC activity. Family history may be notable for sudden death or stroke prior to the age of 40. Treatment includes dietary sodium restriction and direct inhibition of ENaC with the use of amiloride. Note that spironolactone is ineffective since Little syndrome is not due to aldosterone-induced upregulation of ENaC, but a gain-of-function mutation of ENaC. Hypertension may result from increased renal sodium reabsorption due to mutations that can lead to high levels of steroid hormones with mineralocorticoid activity, such as aldosterone, cortisol, and deoxycorticosterone. These conditions include glucocorticoid remediable aldosteronism, syndrome of apparent mineralocorticoid excess, and congenital adrenal hyperplasia. Mutations leading to increased synthesis of the mineralocorticoid hormone aldosterone can lead to upregulation of apical ENaC, ROMK, and hydrogen ATPase, and the basolateral sodium-potassium ATPase. Increased ENaC expression and activity increases sodium reabsorption. All upregulated transporters work in concert to increase potassium and hydrogen secretion. The increased sodium reabsorption via ENaC leads to hypertension, and the associated increase in potassium and hydrogen secretion leads to hypokalemia and metabolic alkalosis, respectively. This is a list of mutations that can increase aldosterone synthesis. The most interesting of which is called familial hyperaldosteronism, also known as glucocorticoid remediable aldosteronism, or GRA. GRA results from the formation of a chimeric gene from uneven crossover of two homologous chromosomes during meiosis, where the transcription of aldosterone synthase is promoted by the adrenocorticotropic hormone ACTH instead of angiotensin II. So what does this mean? This is a DNA segment showing two genes on one chromosome, one encoding aldosterone synthase and the other encoding 11-beta hydroxylase enzyme. Both genes have their own promoters. Aldosterone synthase is the enzyme that's responsible for the synthesis of aldosterone. Normally, the transcription of aldosterone synthase is promoted by angiotensin II, while the enzyme 11-beta hydroxylase is promoted by the adrenocorticotropic hormone ACTH. This demonstrates equal crossover with exchange of genes during meiosis. The resultant DNA strand has mixed genes taken from the two homologous chromosomes above, but both genes have their proper promoters. In patients with GRA, there is unequal crossover of genes that results in this chimeric gene, where the 11-beta hydroxylase promoter is now linked to the gene encoding aldosterone synthase. What this means is the transcription of aldosterone synthase is now promoted by ACTH instead of angiotensin II. A few words about familial hyperaldosteronism, also known as glucocorticoid remediable aldosteronism, or GRA. GRA results from the formation of a chimeric gene from uneven crossover during meiosis, where the transcription of aldosterone synthase is promoted by ACTH instead of angiotensin II. What this means is aldosterone synthesis follows the circadian variation of ACTH, regardless of the body's need for aldosterone. GRA may be treated with the lowest dose of dexamethasone because dexamethasone suppresses ACTH, which in turn turns off the transcription of aldosterone synthase. In general, genetic testing is advisable for patients with onset of hyperaldosteronism at age younger than 20 years and for patients with a family history of primary aldosteronism or stroke at age younger than 40 years. There are steroid hormones other than aldosterone that have mineralocorticoid activity. Cortisol is a glucocorticoid steroid hormone that can exert mineralocorticoid activity similar to aldosterone upon binding to mineralocorticoid receptors. Cortisol can be inactivated to cortisone by the enzyme 11-beta-hydroxysteroid dehydrogenase 2. Loss of function mutation of this enzyme can lead to accumulation of cortisol, thus increased mineralocorticoid activity. Similar to patients with hyperaldosteronism, patients with mutation of 11-beta-hydroxysteroid dehydrogenase 2 and resultant hypercortisolism can also present with the clinical triad of hypertension, hypokalemia, and metabolic alkalosis. Hypertension associated with hypokalemia and metabolic alkalosis due to the loss of function mutation of 11-beta-hydroxysteroid dehydrogenase 2 is called the syndrome of apparent mineralocorticoid excess, or AME. Of interest, other acquired conditions associated with elevated cortisol levels that can give rise to the triad of hypertension, hypokalemia, and metabolic alkalosis include Cushing syndrome or disease and licorice ingestion. The former is due to excess cortisol production from adrenal glands, and the latter is due to inhibition of the enzyme 11-beta-hydroxysteroid dehydrogenase 2. The diagnosis of these conditions may be made with urinary measurements of cortisol and cortisone. A urinary cortisol to cortisone ratio greater than 5 is consistent with the syndrome of apparent mineralocorticoid excess. Both urinary free cortisol and cortisone will be high in conditions with excess production of cortisol, as seen in patients with Cushing syndrome or disease. Deoxycorticosterone, or DOC, is another steroid hormone with mineralocorticoid activity that can lead to the clinical triad of hypertension, hypokalemia, and metabolic alkalosis. Accumulation of DOC may arise from congenital adrenal hyperplasia associated with inactivating mutations of 11-alpha hydroxylase or 17-beta hydroxylase. Of interest, conditions with excess DOC unrelated to congenital adrenal hyperplasia include DOC-producing tumors and the use of abiraterone acetate. Abiraterone acetate is an inhibitor of androgen synthesis used in the treatment of metastatic or castration-resistant prostate carcinoma or androgen receptor-positive breast carcinoma. Abiraterone inhibits 17-alpha hydroxylase, which reduces downstream cortisol synthesis. Hypocortisolism activates ACTH, which in turn drives upstream synthesis of DOC. DOC has mineralocorticoid activity that can lead to fluid retention, hypokalemia, and hypertension. Eplerenone, a low-dose dexamethasone, may be used to treat the clinical manifestations of mineralocorticoid excess associated with the use of abiraterone. Another form of monogenic hypertension that results from increased renal sodium reabsorption is due to a gain-of-function mutation of the mineralocorticoid receptor. This condition is known as Geller syndrome. Gain-of-function mutation of the mineralocorticoid receptor can also lead to increased sodium reabsorption at the collecting duct. It has been suggested that in patients with gain-of-function mutation of the mineralocorticoid receptor, the conformation of the mineralocorticoid receptor's binding site is altered such that it can bind to cortisol byproducts with high affinity and increase ENaC-ROMK hydrogen ATPase activities. This would then lead to increased sodium reabsorption via ENaC and enhanced potassium and hydrogen secretion via ROMK and hydrogen ATPase respectively. This gain-of-function mutation allows the mineralocorticoid receptor to be activated in the absence of aldosterone. Patients with gain-of-function mutation of the mineralocorticoid receptor presents with the clinical triad of hypertension, hypokalemia, and metabolic alkalosis, similar to patients with hyperaldosteronism. A few words about gain-of-function mutation of the mineralocorticoid receptor. The presence of an activating mutation of the mineralocorticoid receptor is known as Geller syndrome. This is an autosomal dominant disorder where the conformation of the mineralocorticoid receptor's binding site is altered such that cortisol byproducts can activate the receptor and exert downstream effects on ENaC, ROMK, and hydrogen ATPase to increase sodium reabsorption and potassium and hydrogen secretion. Of interest, hypertension in this condition may be exacerbated during pregnancy. It is thought that progesterone may stabilize the active site of the mutated receptor, thereby enhancing affinity for its ligands. Due to the altered binding site of the mineralocorticoid receptor in Geller syndrome, the receptor antagonist spironolactone may paradoxically activate the receptor, thereby inducing an agonistic rather than an antagonistic reaction and exacerbating hypertension and electrolyte disturbances. Spironolactone may therefore worsen hypertension. Treatment of this condition includes low sodium diet and close monitoring of patients during pregnancy. It is prudent to avoid the use of spironolactone. Let's now shift our discussion to monogenic hypertension due to increased vascular resistance and vasoconstriction. A mutation leading to increased vascular resistance and vasoconstriction can lead to hypertension. One such known condition is hypertension with brachydactyly. Hypertension with brachydactyly is a rare autosomal dominant condition. The disease is known to cause severe salt-independent and age-dependent hypertension that begins in childhood. Affected individuals can develop significant cerebral vascular disease and stroke before the age of 50. Mutation of the phosphodiesterase 3A enzyme leads to enhanced phosphorylation of PDE3A, thereby gain of function for the enzyme. The enhanced enzyme activity promotes hydrolysis of cyclic AMP, thereby lowering cyclic AMP levels in vascular smooth muscle cells. This in turn increases neointimal proliferation and remodeling of arteries and neurovascular structures, all leading to increased vascular resistance and vasoconstriction, thus hypertension. Additionally, this PDE3A mutation is also associated with dysregulated secretion of parathyroid hormone-related protein, leading to a pseudo-hypoparathyroidism-like state and subsequent brachydactyly and short stature. Treatment is routine management of hypertension. In summary, monogenic hypertension may be related to increased renal sodium reabsorption or increased vascular resistance. Increased renal sodium reabsorption may be due to gain of function mutation of the sodium chloride cotransporter NCC at the distal convoluted tubule, gain of function mutation of the epithelial sodium channel ENaC at the collecting duct, increased steroid hormones with mineralocorticoid activity, or gain of function mutation of the mineralocorticoid receptor. In pseudohyperaldosteronism type 2 or Gordon syndrome, there is a gain of function mutation of NCC at the distal convoluted tubule that results in increased sodium reabsorption via NCC and increased paracellular chloride reabsorption, both leading to volume expansion, hypertension, and a suppressed renin and aldosterone state. Clinically, these patients will have hypertension, hyperkalemia, metabolic acidosis, and in some cases, hypercalciuria and osteoporosis. Pseudohyperaldosteronism type 2 or Gordon syndrome may be treated with direct NCC inhibitors, thiazide diuretics. In Little syndrome, the gain-of-function mutation of ENaC leads to increased sodium reabsorption via ENaC and the associated increase in the secretion of potassium and hydrogen, thus hypertension, hypokalemia, and metabolic alkalosis. Little syndrome is treated with a direct ENaC inhibitor, such as amiloride. Increased mineralocorticoid activity may be seen in a number of conditions, including glucocorticoid remediable aldosteronism, where there is an unequal crossover mutation, where aldosterone synthesis is promoted by ACTH rather than angiotensin II. Syndrome of apparent mineralocorticoid excess, where there is a loss of function mutation of 11-beta-hydroxysteroid dehydrogenase 2, the enzyme necessary for the inactivation of cortisol, resulting in the accumulation of cortisol, which has mineralocorticoid activity. And congenital adrenal hyperplasia, where there is an inactivating mutation of either 11-alpha hydroxylase or 17-beta-hydroxylase, resulting in the accumulation of deoxycorticosterone, which has mineralocorticoid activity. Conditions leading to excess production or accumulation of aldosterone, cortisol, or deoxycorticosterone are associated with hypertension, hypokalemia, and metabolic alkalosis. With the exception of GRA, where patients may be treated with low-dose dexamethasone, all other conditions may be treated with aldosterone antagonists, such as spironolactone or eplerenone. Gain-of-function mutation of the mineralocorticoid receptor, known as Geller syndrome, is a condition where the mineralocorticoid receptor is constitutively activated to result in increased ENaC activity for sodium reabsorption. Patients with Geller syndrome can present with hypertension, hypokalemia, and metabolic alkalosis. This syndrome is characterized by the possible exacerbation of hypertension during pregnancy or with the use of spironolactone. Treatment includes low sodium intake. The use of spironolactone should be avoided. As for the one form of monogenic hypertension, unrelated to increased renal sodium reabsorption, but related to increased vascular resistance and vasoconstriction, known as hypertension with brachydactyly, there is a gain-of-function mutation of phosphodiesterase E3A. In this condition, there is increased phosphorylation of PDE3A, leading to vascular smooth muscle proliferation and vasoconstriction. In addition to hypertension, this condition is also associated with dysregulation of parathyroid hormone-related peptide and an associated pseudo-hypoparathyroidism-like state with resultant brachydactyly and short stature. Treatment is routine management of hypertension. At this time, you should know end organ effects and major clinical manifestations associated with different forms of monogenic hypertension herein presented. You should also be able to identify clinical manifestations and specific therapeutic options for the different monogenic hypertensive conditions. This table summarizes all forms of monogenic hypertension we just discussed, along with their major mutation or defect, clinical manifestations, and specific treatment. Monogenic hypertension is relatively rare. It may be considered as looking for a zebra in clinical medicine. However, a good understanding of the pathophysiology behind the different forms of monogenic hypertension allows the clinician to better spot the zebra and provide proper and direct medical therapy whenever applicable. This is what makes medicine fun.